Joanne Bellata.
And I'm Marianne Harmson. Joanne and I have over 50 years of combined experience in the healthcare industry. We have created a new podcast series, Getting to the Core Issues, which is specifically designed to inform you, the public, about the multifaceted pieces of the healthcare puzzle.
Like you, we are concerned about the rising cost of healthcare and its impact on our economy. Our goal is to relay solutions which are evidence-based and meet the needs of the population. In getting to the core issues, we look forward to interviewing experts who will address their areas of expertise and offer solutions to the healthcare puzzle.
Hello, today we're speaking with Dr. Michael Fine, who is the Chief Health Strategist for the City of Central Falls, Rhode Island, along with being the Senior Population Health and Clinical Services Officer at Blackstone Valley Healthcare. Dr. Fine guides a partnership between the City of Central Falls and Blackstone Valley Healthcare that created Central Falls Neighborhood Health Station, the first attempt in the USA to build population-based primary care and public health collaboration that serves the entire population of a particular locale. Dr. Fine's career as both a family physician and manager in the field of healthcare has been devoted to healthcare reform and the care of underserved populations. Dr. Fine is a former director of the Rhode Island Department of Health, as well as the former medical program director at the Rhode Island Department of Corrections. He was a founder and managing director of Health Access Rhode Island, the nation's first statewide organization making prepaid, reduced fee-for-service primary care available to people without employer-provided health insurance. He has served on a number of boards and legislative committees throughout the state and is a former president of the Rhode Island Academy of Family Physicians, as well as Open Society Institute George Soros Fellow in Medicine as a profession. He serves on numerous boards, including the prestigious Lown Institute. Dr. Fine has written several books on healthcare. He has a new book coming out as of September 1st, 2018, entitled The Healthcare Revolt. It has already garnered impressive reviews. Welcome, Dr. Fine.
Thank you, and thank you for having me.
Happy to have you. Dr. Fine, you're a passionate advocate for healthcare. What drives your passion? How do you see the roadmap unfolding?
I think the thing that drives my passion most is the pain that I see the healthcare market causing and the sense of loss I feel as a physician and as a human being because we don't have a healthcare system that takes care of all Americans. That reflects back on something my grandfather taught me, which was that it is immoral, or he believed it was immoral for people to profit from someone else's misfortune. And what we have done is evolved a market that is only about profit and not about providing the kind of care we could provide in a way that would make all Americans healthier and do it in a way that would be affordable.
That's absolutely on point. We find that looking at the neighborhood health station, there is a difference from community health centers. Can you define for us a little bit what those differences are?
Well, the first thing to realize is that the neighborhood health station is our attempt to build a healthcare system for one community. The neighborhood health station, by definition, is attempting to enroll the entire population of the city of Central Falls and to bring not only routine medical care, but prevention, dental care, mental behavioral health care, substance use disorder treatment, and emergency medical services to the entire community, and to do it as a team of people. Now, how is that different from community health centers? Well, let me take a second to reflect backward on the history of the community health center movement, because few Americans actually know that it exists. Community health centers were, the first community health centers were created in 1964 in Columbia Point, outside of Boston, and in Mount Bayou, Mississippi, by Dr. Jack Geiger, really as part of the civil rights movement. He was thinking about how medical care could be used to equalize the disparities, to address the unfairness that had happened after slavery, particularly among the African American population. But then realized that community health centers had a role in taking care of all Americans living in poverty. And then progressively, we began to understand that community health centers have a role in taking care of all Americans. We now have 1,350 community health centers in the United States, which function at 9,000 locations and take care of 26 million Americans. And they provide the backbone of what could be a healthcare system for the United States. Community health centers differ from neighborhood health stations in the following way. Community health centers take care of everyone who comes through their doors. Community health centers take care of you whether you're rich or poor, whether you have insurance or don't have insurance, whether you're documented or undocumented, and focus on communities where there is relatively poor access to healthcare. But they do take care of only people who walk through the door. Neighborhood health stations are aimed at providing that kind of care for everybody, but doing it so that they take care of every single person who lives in a place. Their job is to think about not only the care of the people who walk through the door, but the care of the entire community, and to focus on improving the measured public health of everyone who lives in that location, neighborhood, or community.
So I would think then that ability to have outcomes that affect an entire area. Let's just say if there's a measles outbreak or there's a flu epidemic, by having everyone within the locale being able to access healthcare not only might be somewhat of a preventative, situation, as well as more desired outcomes. Would that be a fair way of looking at that?
Yeah, it's a kind of interesting, sort of you get a double effect. One is if you're taking care of everyone inside a community, you're actually paying attention to the health of everyone in the community and seeing patterns of disease that you might not see if you only take care of who walks through the door. Mm-hmm. I live in Scituate. There is a community on the Scituate-Foster border that we noticed 20 or 30 years ago had lots of leukemia and lymphoma. The only reason I noticed that is because I'm here and I was for a while the major person taking care of people in this community. So I had my ear to the ground and would hear about things and so on and so forth. And it turned out that there was an old environmental exposure, that there was an old degreasing plant, and some of the water had gotten contaminated, and it's likely that the two were related. But the only reason that I knew that was because I was the one guy seeing everybody. One neighborhood health station seeing everybody. You have the ability to recognize new patterns of disease and respond to it. The other opportunity is the opportunity to make prevention real. Right now in the United States, there's nobody in charge of making sure we all get flu shots. So guess what? Less than 50% of us get flu shots every year. 40% of adults, 60% of kids. If we ever get a vaccine that really works better, our vaccine works okay, but not that well. But if we ever got a vaccine that really worked well, we still wouldn't be effective at preventing the 30,000 deaths a year from influenza because we don't get everybody immunized. And the reason everybody immunized is that nobody's in charge of getting that done. So we have the opportunity to prevent flu and 30,000 deaths a year. We have the opportunity, if you really understand it, to eliminate colon cancer, which is an entirely preventable disease, but only about 50% of us get colonoscopy when we get to 50 and get it every 10 years. So we still have a couple of thousand deaths a year or more from colon cancer that are totally unnecessary. And you can sort of go down the line of things that we could prevent if somebody was in charge of prevention for the whole population. The thing that no American really knows is that nobody's in charge of that.
Dr. Fine, why hasn't anyone implemented a neighborhood health station model?
I don't know, but I think it's because of the way our health policy is so balkanized. That is to say, we really have a market, and the market determines what we're going to do, and the market is about selling services and products, not about improving the health of the population. Another part of it, if you look at the federal level, CMS, the Centers for Medicare and Medicaid Services, is really an insurer that exists to pay for services. They're not in charge of improving everybody's health because they're really only in charge of people who are over 65 and people on Medicaid. In another place, you have the CDC, the Center for Disease Control. They're sort of in charge of figuring out what the best best science for prevention is, but the two don't actually talk to each other. You go on and on about the different organizations who each have federally different responsibilities. There are 4 or 5 of them federally that really don't talk to each other. So nobody's in charge of making this happen. And the beauty of sort of going local, of becoming a localist, of doing this from the ground up, neighborhood by neighborhood and community by community, is it lets communities and neighborhoods take care of their own health and take responsibility for their own health. But it suggests the way to do that is to do it together.
Dr. Fine, what do you think is really driving up the cost of healthcare? And how does this model help that stem some of the trend that's going on?
There are many drivers to the cost of healthcare. One is price. Our prices are higher than most places. One is the insurance process itself, which isolates people from those prices so that when you go to get something, you don't actually pay for it. Somebody else does, and then encourages you to use it more. One is advertising, trying to get you to use more services, whether you need them or not. One is administrative overhead. We have a administrative overhead that actually comes simply out of the billing process itself. Most people don't know that 20 to 40% of the receipts that primary care physicians get ends up going to billing. They spend 20 to 40% paying the people who do the billing and on the collection process and so on and so forth, which is crazy because primary care is an entirely predictable expense. So that's 20 to 40% of that pocket that's basically wasted.
There's such a detachment between the perspective of the population and the commerciality of the healthcare insurers for the most part. One of the things in looking at the integration of health information systems that you refer to in your book was how the electronic health records really are not helpful to you in your practice, or what you've been able to glean from them. Maybe you want to expand on that a bit?
I introduced the first electronic medical record in the state of Rhode Island before most people I know were born. And we had an electronic medical record before there was something called Windows in the early days of DOS. On the one hand, they have huge potential, but the way they got rolled out not as a public program. They got rolled out as a market. So there are 80 bazillion sellers of electronic medical records, and they really exist not to make sure that we protect people's health best. They exist to make sure we bill for services correctly and maximize our income by billing, not by taking care of human beings. Much of what clinicians have to do when they use electronic medical records, nurses and doctors and nurse practitioners, all of us, is, we get there are all sorts of things in the electronic medical record that ask us to pay attention to how we can bill more money and generate more income, right, instead of how we can pay attention to the person in front of us best. In the United States, the tail really wags the dog. In other countries, clinicians love their electronic medical record because they let them take care of people. So, if I'm a primary care clinician in Finland or in the UK or in Ireland, I can go on and know what's going on with all my patients. And if somebody's in the hospital, I know what's going on with them every minute. And conversely, if I'm a hospital doctor and I'm seeing somebody for the first time, I can open up their electronic medical record and know all about them without having to ask the same dumb questions over and over again. Everybody who's a patient has the experience of every time we go to a doctor's office, every time we go for an x-ray, we get asked to fill out the same dumb form with the same dumb information. When my dad died a year ago, he died of the same thing each month after he died. So for me to say over and over again what he died of is just inefficiency. But it's an efficiency that all our fancy electronic medical records haven't gotten us past because, like I say, they're about billing. They're not about patient.
And you bring up a very good point. How does the current reimbursement system impact the delivery of care and its affordability? Because the billing right now, I had the opportunity to work with a clinic in getting them credentialed and looking at their billing system to help them get paid. And even though they have sort of streamlined some of the billing codes with ICD-10 and other initiatives to try and make it simpler, I find that adds an additional complexity to the way we're paying for healthcare. It's all focused on treatment, but not prevention. And on the other hand, it's adding staffing and additional cost into, the physician's cost of goods sold which then has to be passed on to health insurance carriers and others.
The current system, the payment system, which we sometimes call fee-for-service, means that people get paid for doing stuff. They don't get paid for not doing stuff, which is one huge problem, because a lot of people are better off when they don't get things done. People get paid only when they provide a service or sell a product. And so, like moths to the light, people with something to sell work to provide services for which they get paid, not the services that people in communities need. So there's no incentive to tell someone they don't need surgery. There's no incentive to tell someone they don't need a medicine. And so the whole fee-for-service approach, this paying for each service, has created all this activity to sell stuff, or much of which is unnecessary or even dangerous. It has been the major source of the destruction of what might have been a healthcare system, and instead replacing it with a healthcare market. And that's a little crazy making, because we know that many healthcare costs are entirely predictable. And so if we paid for them by the month instead of by the service, if each primary care physician was paid $40 or $50 a month to take care of each of you, then there would be no incentive to do more stuff. The incentive would be, and can be structured, to be there to make sure that you have what you need and that we improve the health of the population together. The incentive to be built into that approach is the incentive that encourages primary care practices to do prevention, to make sure that everyone in the neighborhood or city they take care of has had a colonoscopy, and everyone has had a flu shot, and everyone has been tested for HIV. These are critical, simple population health interventions that really improve the health of the population and really drive down costs.
Do you see, Dr. Fine, the neighborhood health stations trying to get perspective on, would this be a format that is somewhere between what some of the former presidential candidates wanted to do in terms of a single payer system? Do you see any role for commercial carriers involved in the neighborhoods or in supporting your efforts?
First of all, this is a different point than single payer. Single payer is about basically who's going to be the insurance company. Are there going to be commercial insurers, or is the government going to pay for everything? But single payer, when you really get down to its basis, is about just a different way of having insurance work. But it's about insurance. It's not about what a healthcare system looks like. This is kind of more fundamental. It says the first thing we need to do is build a healthcare system, and then we know how to figure out how to pay for it. But without a healthcare system, we end up with this market, regardless of who the payer is. Right. And this market is so insidious that it drives up cost and doesn't effectively help us reduce illness. Now, the role of commercial payers can do this 100 different ways, but if you ask me, and I guess you are, the way I would see doing it is we ought to build one neighborhood health station for every 10 to 20,000 people. We ought to pay for it publicly, some version of out of tax dollars. And there are a couple of different ways of doing that. When you really understand it, that means that 90% of the services people need are provided effectively for free in their own communities. Now, if you ask me again, I would also love to see hospitals be publicly funded in a similar way. And then the role of commercial health insurers is to purchase other kinds of services, very expensive services, or, help pay for specialists and for things that are more discretionary. I don't want to go to a public hospital. I want to go to a private hospital, things that are more up to the person. And so that says, yes, there's a role for commercial insurers. It's just smaller than the role that we see now. If you think about it, we do something really weird, which is we're buying healthcare through insurers under a umbrella called insurance, which was designed to pay for things that are, in fact, catastrophic. But
Right.
We're using these insurers to pay for things that are essential services.
Absolutely.
Primary care, for example, shouldn't be in the insurance process at all. Primary care is an entirely predictable expense. We know what it costs per person per year. We know it's really affordable. We know everybody needs it. It's sort of more like elementary education or like police services or fire protection. These are essential services that we provide for ourselves together. Mm-hmm. And we ought to do at least the primary care part in the same way.
So do you think the funding of these neighborhood health stations should be more like a bundled rate with some quality measures and maybe some incentives to focus on that prevention versus versus a fee-for-service model.
Exactly. Not only do I think that a little bit, that's exactly what I think. I think primary care practices should be paid a certain amount of money per person per month, but they ought to be measured on 4 different domains. First domain is they should be measured on open access and extended hours. They get paid better, it seems to me, if they're open from 8 o'clock in the morning to late at night and open on weekends than they would if they're only open 9 to 5. They get paid better if everybody who is a patient of theirs is sick today, can be seen today. You never call up a primary care practice and say, I have a sore throat, and have them say, come in 2 weeks. That's our next opening. The ability to see you the same day is just practice management. I've done this before. I know how to do it. It's not hard. You just have to understand some things about how you organize practices to make this entirely doable. But everybody should be seen the same day they're sick in their own communities at a time that's convenient for them, instead of everybody having to distort themselves to figure other stuff out. So first domain, open access and extended hours. Second domain is breadth of services. Every primary care practice needs mental and behavioral health as part of the practice. Every primary care practice needs physical therapy as part of the practice. Every primary care practice needs lab and x-ray on site, and every primary care practice needs substance use disorder treatment right there, so that people can go to one place and get the services they need from a team of people who are talking to each other and are thinking about how to take care of each individual human being. Third domain, primary care practices ought to be paid on basic public health indicators, but just a few. We ought to judge primary care practices on their vaccination rate, because that's a critical public health outcome. We ought to pay primary care practices on whether they've tested all their patients for HIV. That's a critical idea. We ought to pay primary care practices probably on their colonoscopy rate and on their smoking rate, the percentage of smokers in their practice. That's it, because they ought to be working with all their heart and soul to get those people to quit. We probably ought to be paying people on what the average BMI is, the extent to which people are thin or overweight, because that's a critical public health indicator. And that's about it. In the primary care world, we measure 50 to 100 different kinds of things, which means primary care practices have no blinking idea what it is they're supposed to concentrate on. You reduce it to 2 or 3, and we can really get them moving.
One other thing in there too, because I'm the campaign chair for the Choosing Wisely initiative. What I feel is that some of those recommendations for unnecessary tests and treatment should also be part of that measurement, so that the wasteful spending of healthcare starts to be reduced through better practice and better communication between patient and doctor.
I think that's right. And one of the other things you can measure primary care practices on is how much their patients spend on additional services that may not be necessary. But the art is to keep the number of measures to just a few, because everybody wants to add one more measure to the primary care back. And that's one of the things that has been breaking the souls of primary care physicians over time. And that's something we need to pay attention to, because those physicians and nurse practitioners, those clinicians, are really critical to the health of the state and of the nation. Anyway, and the fourth domain that we ought to be comparing primary care practices on is something that we call population penetrance, the extent to which each practice has enrolled close to 90% of the people in their service area. Because of what I said before, the closer you get to 90%, the more you have the ability as a practice to have your practice work improve the health of the public. It gives you the opportunity to see emerging patterns of disease. It gives you the opportunity to decide what as a practice to focus on. And so getting everybody, being an attractive enough place so that everybody in the community wants to go there is something that we ought to measure, because it will tell us the extent to which each practice is paying attention to its community and doing a good job.
Dr. Fine, one of our guest speakers has been Dr. Robert Smith, who's written a few books, and in particular, a book about teaching physicians to integrate behavioral health and mental health into their primary care practice. He was explaining to us that out of a 4-year medical degree, 3 years of residency, there's about 6 weeks devoted to that. And he's using a model that was created that actually addressed famine in the world and the way we spread. America went out in the 1930s and 40s, and using technology we developed in our after the Dust Bowl situation, and using that model to teach people around the world how to farm so that we could reduce the famine. It was a very successful model, and he's replicating that in terms of teaching medical students about the integration of behavioral health at the primary care level. So it's exciting to hear you say that is one of your 4 fundamental tenets. We also have been in touch with Maria Shriver, who's put together a program called Architects of Change. At some point, we're hoping to get her involvement. You've been in the state a long time. Have you had discussions with Patrick Kennedy at all in terms of mental health or substance abuse or the integration of care?
Congressman Kennedy actually thought up some of these ideas. We had lunch together 10 or 15 or 20 years ago, and he kind of intuited that we needed to be putting these 2 different domains together and focusing on how to provide primary care to everybody. The answer is yes. We have had those discussions. I've been really pleased to see his personal evolution into this realm of working on both mental behavioral health and its integration, and just to see how just to see how his family has developed. It's been a beautiful thing to watch.
It has been. We were looking at, in terms of the pharmaceutical industry, Dr. Fine, where you think the most success may have been, and where, in terms of recurrent premature delivery, you've seen some obstacles.
The pharmaceutical industry as a whole is hard for me to talk about because I can't, from a research and development perspective, because it has a fairly tight connection to government and some government-funded research. I have some issues with the notion that some of that foundational research has turned into private profit. And I think we should be way more thoughtful about making sure that public investments turn into public savings in huge public expense. Anybody who's practiced has seen the manipulation of the pharmaceutical markets in a way that's heartbreaking. Medicines that used to cost next to nothing now cost hundreds of dollars. I was talking last night about doxycycline because I get Lyme disease. I've had it 3 or 4 times in my life. Doxycycline used to be pennies, and it's now hundreds of dollars. They've done this. They've found a way, and I keep, different pathways for different drugs. They found a way to make medications that have been around for a long time and are very effective. They found a way to make them egregiously expensive. The medication you referenced is a medication that is used to prevent recurrent premature delivery. That medication is a hormone that was synthesized in the 30s and was cheaper than water. There was some research done on it about 10 or 15 years ago when it cost $5 a dose. And typically a woman who's had a premature delivery needs 1 shot a week for about 20 weeks. $5 a shot was next to nothing. There were some people, some of whom were here in Rhode Island, who did some of that research, found that it was tremendously effective. And then a drug company took the medication through an FDA process, declaring it an orphan drug. And when it came out, that $5 a dose turned into $1,500 a dose. And it turns out the bulk of that is paid by the public purse because most of the women who have recurrent premature delivery are women on Medicaid. And so we end up paying that extra cost. And the perversity is that someone used a public process at the FDA to distort the market so that the public as a whole has to pay the freight. Like, fool me once, we're getting fooled twice. Shame on us. And that's where having more thoughtful leadership around healthcare, that's where having somebody in charge becomes so critically important instead of just depending on the market.
That's what I was just going to say is that, it goes back to your point of having a market and not a healthcare system.
Well, Dr. Fine, I think we could speak to you for hours and hours, and we're looking forward to the release of your book, The Healthcare Revolt, and we'll be hopefully able to interview you at other times as well.
It would be my pleasure. Thank you.
Thank you, Dr. Fine.
Thank you for your interest and for your great questions. You guys are really paying attention as few other people do.
Well, this is our passion. We've been, in healthcare combined over 50 years. And we've been trying, desperately to make change to the healthcare system. But as you know, it's a big mountain and it takes lots of people joining together to make change.
Remember, somebody is taking $1 trillion to $1.5 trillion out of the system. We pay $1 trillion to $1.5 trillion extra that we don't need to pay. That money is coming off as somebody's profit. $1.5 trillion is a lot of money to have to spend to defend the money that you already have. And that's what we're up against and why this is going to take not one podcast or two podcasts, but it's going to take a movement and every single American involved with figuring out how to provide health care community by community, with communities building little systems for themselves.
Absolutely, for sure. And I tell people that, it's interesting, and I'm sure you find this as you go through your life, that there are certain people, especially if they've had employer-based insurance, that are, if you drew a line, they're kind of removed from the everyday realities of some of the costs, the exorbitant costs, because even if they have a contribution level, some of them have experienced certainly higher co-pays, higher deductibles. But if they're in a financial bracket that it hasn't really impacted them, they are not concerned about the community level. So I try to make it very clear to them that our purpose is to start a grassroots effort to address the population that hasn't been served. We're not trying to be disruptive to anyone, and if they're happy with certain things, but other things can be addressed and can be altered and amended. Like anything else, there's an evolution. So that's where Joanne and I, it's been a passion with us for a long time, and thank you so much for a truly enlightening interview. And like I said,
join us again on our podcast. For more information about Dr. Fine and his new book, visit our website at www.exitjq.com. And don't forget to share this podcast with your family and friends. Tune in for our next podcast for more solutions to the healthcare puzzle.